Many times yesterday we talked about, in several sessions, about the fact that we use the term cancer. But cancer really is probably hundreds of different diseases occurring in each of us in very different ways. It is a disease that arises from changes within our DNA and changes that we bring into our lives, inherited changes, but also changes that occur throughout our lives. So as we bring in what we're born with, but we live in this environment, so we're exposed depending on where we live. I grew up in Steubenville, Ohio. I think it still rates as one of the most polluted communities in terms of air quality in the country. Exposed to infections. And we make certain life choices. Tobacco is one, but obesity, exercise, diet, other things are part of those choices. And we have this process that we can't avoid called aging, and we know that this is a disease primarily of aging. I show you this to remind you of the fact that this is a disease of very staggering complexity, and this complexity is almost occurring daily as we learn more and more about the disease. The tumor lives within tissue that we felt was normal tissue, but that we know now is surrounded by cells that change. Even though they look normal, they have a different genetic expression, so that the fibroblasts are different, the endothelial cells of the blood vessels are different, and cells of the immune system also come into play. So this is a dynamic process. And notice up here I've highlighted two cells in red, and we're just beginning to try to understand what perhaps a very small percentage of cells in this tumor, what role they play as potential stem cells or stem-like cells. Now, our advances in science and in cancer have been tremendously moved forward by the Human Genome Project. And subsequently, the effort in developing the HapMap to identify those small differences that occur between each of us. We call those single nucleotide polymorphisms, as the artist is depicted here, and that's how we differ one from the other. And the ability to use these differences to map out potential areas within our genome of risk. For example, if we look at SNP-A, you can see in looking at a large cohort of patients, several thousand patients to begin with, some with colon cancer and some unaffected, about 1,000 plus in each group. No real difference between this with SNP-A, but with SNP-B, we see a clear difference for those that have colon cancer. So we can pick that particular SNP region as a region that might predict risk for developing this disease. We know that these SNPs travel in neighborhoods, and so we can use a small number of these as proxies for finding areas of risk for disease, cancer and other diseases. So we have a huge effort and investment at NCI in developing whole genome scans to identify areas of risk. We've done that in prostate and in breast cancer, in colon cancer. We're beginning one in pancreatic cancer, and we are also beginning one in AIDS. This slide shows you that we have also a significant effort, along with the Human Genome Institute, in also sequencing tumors to see if we can identify changes and predictors of risk and predictors of behavior of the individual tumors. So the emphasis, the science, is taking us to use these new technologies, to use these new tools. And many, actually, the ability to do whole genome scanning, it was not there 5 years ago. This is something that we've just been able to do in the past, really, couple of years. So diseases disease with genetic component, identify genetic defects, move towards diagnostics, preventive medicine, studying the individual in terms of how you will handle given therapies, and of course, the foundation for developing new targets and new therapies. I've tried to show you this in another way. Here is the healthy patient, establishing the cancer risk, predicting the course if you should develop risk, cancer, whether you will have an aggressive course or not an aggressive course. Determine optimal drug metabolism, how you will metabolize, how you will manage or handle a given drug that you may receive, and therefore being able to predict dose and toxicity. If you develop disease, determine the unique genetic and epigenetic changes of that particular tumor in you, and define not a specific therapy, not one single agent in almost every case. But I wanted to remind you that these are networks of change within the cells of the cancer and within the cells supporting the cancer, those so-called normal peritumoral cells, if you will. So we need to develop networks or solutions, rather, of therapy, not specific or single therapies. Now, one of the barriers that we're going to, I'm sure, talk a lot about is this problem of developing the drug, the new agents that we want. And I've tried to depict that on this particular slide. And you can see the cost here and the time in years. We have a number of projects going on at NCI right now. The Clinical Trials Working Group that provided us with a report and a set of recommendations. The Translational Research Working Group, also a set of recommendations. We've put in place a team that will help us implement that, and we are allocating resources to help implement those recommendations. We've developed a phase 0 approach to drug discovery, which I think is revolutionary. We have put new resources into our RAID, our drug discovery program, and we're developing a chemical biologic consortium to facilitate drug discovery. These are all things that we've initiated within the past 18 months since I've been at the National Cancer Institute. Our goal is to work on this particular barrier, or this particular problem, to reduce it with a target of 6 years. Finally, just some thoughts. There's never a more exciting time, I believe, in science, and I think you have heard that repeatedly yesterday and again this morning. These changes that this science and the changes that are taking place will certainly completely revolutionize medicine. The practice of medicine will not be the same in a decade that it is today. We will have great opportunities, I believe, in prevention. We will be working in a highly personalized approach. We will have treatment solutions, and hopefully most of those will be directed at prevention. I also put this at the bottom of the slide. This is also going to revolutionize the way we do science. The way we do science 5 years to 10 years from now will not be the way that most of us in this room grew up doing science in our laboratories. And that's going to require also significant change.
So since I don't have a microphone, I'll stand here. First, I'd like to thank the organizers for inviting a pediatric oncologist to be part of this. From an economic point of view, pediatric oncology is actually not an important problem. Only 1% of cancers are found in children. And we feel that on a day-to-day basis when you look at the economics, when you look at industry-sponsored trials, we don't make a lot of money for the industry. So I'd like to really thank the organizers for bringing pediatric oncology on the stage, because we really feel part of the whole oncology world.